Thank you for joining the COVID Community Impact Survey Spotlight webinar on mental health. In this webinar, we are going to talk about some of the ways in which the COVID-19 pandemic has impacted the mental health of Massachusetts residents. My name is Ta-Wei Lin, and I am an epidemiologist for the Massachusetts Department of Public Health, and I will be the presenter for this webinar. The information presented in this webinar was prepared by my wonderful colleagues referenced on this slide. This is a reminder that this webinar is meant to be watched after you have already seen the CCIS introduction webinar. The introduction contains important background information explaining how to interpret these results, how we did the survey, and how to frame these findings with a racial justice lens so that we can all turn the CCIS data into action. And you can visit mass.gov/COVID survey for more information. The work of the COVID Community Impact Survey was done in collaboration with a huge team of dedicated individuals from the Massachusetts Department of Public Health, Health Resources in Action, and John Snow, Inc. This work would also not be possible without our wonderful community partners, some of whom are listed here on this slide. I don't have the time to acknowledge all of our partners individually, but this work truly could not have been done without their help. Now I will talk briefly about the purpose and intent of this webinar. In today's webinar, we will share some key findings from the COVID-19 Community Impact Survey and its impact on mental health. The goal for these findings are to inform immediate and short-term actions, identify ways to advance new collaborative solutions with community partners to solve the underlying causes of inequities, and to provide stakeholders at all levels information to make the case for a healthy future for all. Again, visit mass.gov/COVID survey for all of your CCIS needs, including access to data tables and other webinars. As you saw in the introduction webinar, framing is critical to understand the results you will see in this webinar and to interpret those results using a racial justice lens. Despite the common belief that poor mental health is associated with an individual's ability to cope, the data shows us that there is a strong association between mental health and the stressors people experience, including employment, childcare, access to food and housing, discrimination, and much more. For this reason, clinical services are not enough to address poor mental health. Structural change, such as increasing equitable access to care, is needed for sustainable change. There are two aspects of mental health that were captured within this survey. Oops, sorry. Looks like my slide deck cut out there for a sec. The first aspect looks at how residents with the most persistent poor mental health were impacted by the pandemic. To capture this, we used a standard item from the Centers for Disease Control and Prevention Behavioral Risk Factor Surveillance System, which asks respondents, how many days during the past 30 days was their mental health not good? The second aspect looks at how the pandemic has impacted the mental health of all residents. To capture this, we use an adaptation of the primary care post-traumatic stress disorder screen, which asks respondents how many PTSD-related reactions to the pandemic they had experienced in the past month. Let's begin exploring some of the results from the CCIS. Overall, 1 in 3 adults in Massachusetts reported 15 or more days of poor mental health in the past 30 days at the time of completing this survey, which is 3 times higher than the rate found in the 2019 BRFSS survey. Of the subpopulations experiencing high rates of poor mental health, respondents with disabilities experienced the highest rates of 15 or more days of poor mental health. This includes 72% of residents with a cognitive disability, 56% of residents with self-care or independent living disability, 49% of residents with vision impairment, and 44% of residents with mobility disabilities. And nearly 1 in 2 caregivers or persons with special needs and parents of children with special healthcare needs reported experiencing high rates of poor mental health. The CCIS also captured significant disparities in poor mental health outcomes by gender identity, sexual orientation, race and ethnicity, age, income, and education. Respondents of transgender experience, non-binary respondents, and respondents questioning their gender identity reported the highest rates of poor mental health. Within sexual orientation, LGBTQ+ residents reported the highest rates of poor mental health compared to heterosexual respondents. This includes 59% of respondents that are queer, 58% of respondents that are questioning or not sure of their sexual orientation, and 55% of respondents that are bi or pansexual. Within race and ethnicity, multiracial, American Indian or Alaska Native, and Hispanic Latinx respondents reported higher rates of poor mental health than white, non-Hispanic, non-Latinx respondents. Within age groups, respondents under the age of 65 reported higher rates of poor mental health than respondents 65 and older. And within income group, residents who reported an annual income of less than $35,000 had the highest rates of poor mental health compared to other income groups. All of these demographic groups were also more likely to have 3 or more PTSD-like reactions in the past 30 days, with the exception of Hispanic and Latinx respondents. Respondents who reported any days of poor mental health were more likely to experience delayed care, including both routine and urgent mental health care. Of respondents that reported 15 or more days of poor mental health in the past 30 days, 24% reported not getting the care that they needed. 28% reported delaying routine mental health care, and 37% reported delaying urgent mental health care. Populations that were most likely to experience delays in urgent mental health care reported as bisexual or pansexual, respondents with cognitive disabilities, and respondents between the ages of 25 and 44. Among respondents who reported 15 or more days of poor mental health, the top reasons for delaying any healthcare included appointments that were canceled or delayed, being worried about getting COVID from in-person care, being worried they could not afford the care or that their insurance didn't cover it, and not having a private place for a phone call or video chat. As shown in the previous slide, nearly 30% of adults who reported 15 or more days of poor mental health experienced delayed routine mental health care. However, when we take a closer look at this group, we reveal even more striking disparities. Of adults who reported 15 or more days of poor mental health care, 59% of results of transgender experience and 54% of non-binary respondents also reported delayed routine mental health care. Within sexual orientation groups, 43% of bi or pansexual respondents and 40% of queer respondents reported delaying routine mental health care. Within race and ethnicity groups, 43% of American Indian and Alaskan Native and multiracial respondents reported delaying routine mental health care. Within age groups, 41% of respondents 25 to 34 years of age reported delaying routine mental health care. Within income groups, 39% of respondents that reported an annual income of less than $35,000 reported delaying routine mental health care. 54% of respondents with a cognitive disability and 45% of respondents with a self-care or independent living disability reported delaying routine mental health care. And finally, 46% of caretakers of adults with special needs reported delaying routine mental health care. Respondents who reported poor mental health were 5 to 7 times more likely to request health resources compared to those who reported no days of poor mental health. The top 5 resources requested among respondents with 15 or more days of poor mental health include talking to a health professional over video chat, meeting in person with a health professional, information on how to see a therapist, talking to a health professional on the phone, and using an application on a mobile phone or tablet for mental health support. There are also a high percentage of requests for suicide prevention and crisis management resources within specific populations, including many of the same groups that reported higher rates of poor mental health. The groups that reported the highest need for suicide prevention and crisis management resources include respondents of transgender experience, non-binary respondents, and respondents questioning their gender identity, LGBTQ+ respondents, respondents ages 25 to 34. Looks like it keeps popping me out, sorry about that. Hispanic Latinx respondents, respondents with lower incomes, those with low educational attainment, respondents with disabilities, caretakers of adults with special needs, and those who speak a language other than English. And many of these groups also reported higher rates of poor mental health across both indicators. Respondents who reported 15 or more days of poor mental health were also much more likely to be impacted by the social determinants of health when compared to respondents who experienced 0 days of poor mental health. This includes being 2 times more likely to have a delay in healthcare, 2.4 times more likely to have a change in employment to take care of a child or children, 2.6 times more likely to worry about getting medication, 2 times more likely to be very worried about getting COVID-19, 2 to 3 times more likely to worry about getting access to basic needs, including healthcare, technology, and childcare, 2.5 times more likely to worry about expenses or bills, and 2 to 3 times more likely to request resources that would be helpful to them. So what are some of the key takeaways from the information presented in this webinar? The first takeaway is that persistent poor mental health has tripled during the pandemic. The second takeaway is that respondents who reported poor mental health were also more likely to experience delays in seeking care, having a change in employment due to childcare reasons, worry about accessing basic needs, worry about paying for expenses, and more likely to request relevant resources. And while all demographic groups experience an increase in poor mental health, LGBTQ+ respondents, respondents with disabilities, American Indian, Alaskan Native respondents, Hispanic, Latinx respondents, multiracial respondents, respondents ages 25 through 44, respondents with lower income, and caregivers of adults with special needs are disproportionately experiencing poor mental health. These groups also experience discrimination and face barriers related to access to food, housing, and care. Thank you very much for tuning in to the CCIS Mental Health Spotlight. If you would like more information on how residents of Massachusetts have been impacted by the pandemic and how we can all work together to turn these data into action, please visit mass.gov/COVID survey. We hope to see you in another webinar soon.